Welcome back to part 4 of our explainer on mastering myocardial infarction ICD-10-CM coding guidelines. I'm absolutely thrilled to have you here. Today, we're putting on our clinical detective hats. We aren't just looking at codes today. We're diving deep into the medical record to decipher complex lab values, kinetic biomarker curves, and diagnostic reports. If you've ever felt totally lost in a sea of laboratory data, trying to justify an MI diagnosis, well, you're exactly in the right place. Here's our roadmap for the next few minutes. We're going to cover investigating chest pain, the diagnostic workup, decoding troponin dynamics, infarction versus injury, and advanced MI classifications. Let's jump right in. Section 1. Investigating chest pain, the scene of the event. Every good detective story starts right at the scene of the event. So as medical coders and CDI specialists, how do you find the truth when a physician's chart notes are just ambiguous? We've all seen those charts, right, where chest pain is scribbled down, but the definitive diagnosis is left completely dangling. You really have to know what clinical clues to look for so you can query the provider effectively or assign the precise ischemic heart disease code. It all starts by identifying the classic symptoms in the history and physical. We're looking for documentation of sudden crushing chest pain, particularly pain that travels or radiates straight into the jaw or the left arm. And you've got to keep an eye out for associated symptoms too, like shortness of breath, dizziness, and nausea or vomiting. When a patient with known heart disease experiences pain that is just way worse than usual, or maybe it comes on with far less activity, those alarms should be ringing. That alerts us that we need to investigate the objective data further. Section 2. The diagnostic workup, gathering the evidence. Okay, so once the clinical picture points to a potential cardiac event, it's time to look past the symptoms and dig into the test results. You're going to want to audit the chart for a few specific modalities. First, look at the 12-lead ECG for any ST elevations or depressions. Then, check the echocardiogram for wall motion abnormalities. You'll also want to look for cardiac MRI or coronary angiography and left heart cath reports to see the actual blockages. But most importantly, pay special attention to the absolute star biomarker in our cardiac enzyme panel, cardiac troponin I, or CTNI. Section 3. Decoding troponin dynamics. The smoking gun. Troponin is literally the ultimate smoking gun in our investigation. It's a protein that gets released into the bloodstream when the heart muscle is damaged. But to read its kinetic curve, the crucial point is establishing the baseline. So what actually makes a troponin level officially elevated? Well, we're looking for cardiac troponin values that are greater than the 99th percentile of the upper reference limit. If you see lab values crossing this specific threshold, you've got documented myocardial injury. But wait, hold on, injury does not automatically mean infarction. Let's map out this clinical decision tree because it's absolutely vital for your coding accuracy. Step 1, you identify that elevation above the 99th percentile. Step 2, you look at the serial lab draws to observe for a kinetic rise or fall in those values over time. And step 3, you absolutely must confirm the presence of acute ischemia in the documentation. We're talking things like ischemic ECG changes or a thrombus on angiography. You literally need all these pieces to complete the puzzle. Section 4. Infarction versus injury, solving the case. To completely solve the case and differentiate our ICD-10 codes accurately, we have to separate a true MI from other types of heart injury. On one side, a true acute MI requires a troponin rise and fall with clinical evidence of acute ischemia. That gives you your type 1 or type 2 MIs. On the flip side, if you have a troponin rise and fall but without any acute ischemic evidence, you're looking at acute myocardial injury. Think of conditions like acute heart failure or myocarditis. And finally, if the troponin is elevated but remains stable without rising or falling, well, that points to chronic myocardial injury, such as in patients with chronic kidney disease or structural heart disease. Understanding this dynamic is a total game changer. It prevents massive coding errors. Before we get into the heavy advanced coding guidelines, here's a quick anatomical breather for you. Unlike our human patients whose hearts are safely tucked in their chests, a shrimp actually keeps its heart right inside its head. No way, right? Just a little fun fact to reset your brain before we tackle the complex MI classifications. Section 5. Advanced MI classifications. Categorizing the finding. All right, let's refocus and see how this biomarker evidence builds into our specific ICD-10-CM classifications. First up is the type 2 MI, coded as I21.A1. This occurs secondary to cardiac stress due to other causes. It's a classic supply and demand mismatch. There's myocardial necrosis, but without atherosclerotic plaque rupture. The vital coding rule here is sequencing. You must code the underlying cause first, such as anemia, paroxysmal tachycardia, or COPD, and follow that with the type 2 MI code. Next up is the type 3 MI. Sometimes the clinical evidence is, unfortunately, cut short. Type 3 MI is used for patients who suffer cardiac death with symptoms suggestive of myocardial ischemia, like new ECG changes or ventricular fibrillation, but they pass away before we can draw those crucial blood samples for troponin, or before the biomarkers have had time to rise. Finally, we have type 4A MI. This specific classification occurs entirely in the context of PCI and stent implantation. In this scenario, the cardiac biomarkers turn positive and indicate an infarction strictly as a result of the percutaneous coronary intervention procedure itself. It's a highly specific scenario that really requires a careful review of the operative and post-op lab reports. So let's wrap this up with the coder's golden rule. Elevated troponin kinetics plus clinical evidence of ischemia equals a highly accurate acute MI diagnosis. Master this kinetic formula. Trace the labs alongside the ECGs and angiograms, and you'll never be lost in a vague chart again. You have the tools to query confidently and code accurately. So when you look at your very next patient chart, what subtle clinical clues might you be missing? Keep investigating those charts. And until next time, decode healthcare with Harshal.